is Marla Levine. We will be discussing lung ultrasound and how this can be used in your pediatric patient. The purpose of this lecture is to help you understand the various sonographic signs that can help you diagnose pneumothorax, pleural effusion, pneumonia, pulmonary edema, and bronchiolitis. To perform a lung ultrasound, you will use the linear probe when imaging the anterior chest. And you will use the curvilinear or phased array probe for imaging pathology that is better visualized in a position of dependence, so in the base of the lung in the mid-clavicular line. We will now go over the scanning protocol.
So today we're going to be imaging the lung. And specifically when you approach lung ultrasound, I want you to think about each lung as 4 separate zones that you're going to be scanning. So in total, you would look at 8 different locations for the entire chest. When you're imaging the zones, I want you to think about the first 2 zones being the mid-clavicular line, so that's zone 1 and zone 2. And the mid-axillary line is going to be zone 3, zone 4. And you're looking for different pathology in each separate zone. Starting with the mid-clavicular approach, I'm going to use my linear probe. My linear probe is used specifically when I'm curious about the pleural line. So here I'm going to put my probe down with probe marker towards the patient's head. And I'm going to look specifically at the pleural line between 2 ribs with shadowing. And what I'm demonstrating here is the movement of the pleura, the visceral and parietal pleura moving against each other as a sign of lung movement, the dynamic movement of the lung. And then I can scan lower, again, to show that I have movement of the lung. If I wanted to confirm this movement in a still image, I could put an M mode spike over this segment and demonstrate lung sliding. As expected, if I had a patient where I was concerned about pneumothorax, I would not see this dynamic movement of the pleural line. Additionally, you can have evidence of underlying infection, specifically with cases of bronchiolitis. You would see a pleural line that was not perfectly straight, but little bumpy and lumpy as evidence of subpleural consolidations. So this is another pathological entity that you can identify just on imaging the anterior aspect of the chest. Not surprisingly, disease processes that are not reliant on dependency, so are not heavy. So specifically when you're concerned about pneumothorax, it's going to take the position of least dependence. You can decide to go into a lung preset. The lung preset is going to have a lot less post-processing, and so you'll see a little bit more of a granular appearance to your image. As you can see over here, it looks a little bit grainy. You can still see the pleural line, or rather, you could still see the diaphragm meeting the spine and the fact that there's no extension of the spinal stripe. I prefer, however, imaging an abdominal preset when I'm specifically concerned with the possibility of pleural effusion or pneumonia. I like the appearance more in this preset. And so you can see over here with our patient, we have the diaphragm meeting the spine. And with gentle breathing, We can see that there's no extension of the spine north of the diaphragm. One area where you would want the granularity and the lack of post-processing is when you're concerned about pulmonary edema. In this situation, I'm going to look all over all 4 zones for the presence of B-lines.
Stop, look, and listen. These healthy lungs filled with air causes the ultrasound beam to ping-pong from the probe to the pleura. Normal A lines here. This is A-OK. These unhealthy lungs filled with fluid in the alveoli causes the ultrasound beam to ping-pong inside the water bubbles. Abnormal B lines here. This is bad.
B-lines are an artifact, and with some of the newer machines, there's so much post-processing that they will remove essentially the possibility of seeing those B-lines because they represent artifact. So you want to use a lung preset that will allow you to see all of the artifacts because, as we discussed, lung ultrasound is really a study of artifacts. And you would repeat all of your imaging on the other lung field as well. The complete lung ultrasound involves all 4 zones on each lung field, and that completes the lung ultrasound scanning protocol.
So you can see in the normal appearing chest, you're going to image in the mid-clavicular line, and you're going to demonstrate 2 ribs in shadowing. And what you'll see is the movement of the pleural line, essentially the movement of the visceral and parietal pleura against one another. So this shows the dynamic movement of the lung. Over here you can see the horizontal repeating pattern of lines. These are called A lines, and they are a manifestation of reverberation artifact, a normal lung finding. And in this last normal view, you will see that when you're imaging in a mid-axillary line, you're imaging so that you see the diaphragm meeting the spine. And then you should see no anatomy north of the diaphragm. And this is because air is a poor conductor of sound waves. So if there is no fluid or liquid medium within the thoracic cavity, there will be no acoustic medium to transmit this acoustic energy. And so without any liquid within the chest cavity, you see an absence of all anatomy north of the diaphragm. That's opposed to when you do see fluid within the chest cavity, you will start to see various anatomy, and we will discuss this further in the upcoming clips. Over here you can see when you have an absence of lung sliding, you'll see no movement of the pleura, and that's the image on the left, versus the image on the right where you can see normal lung sliding between 2 ribs. If you move into an M mode imaging, you will see that when you have the absence of lung sliding, you have an absence of movement, the full depth of the lung. And so what you will see in this situation is something called a barcode sign, which is basically looks like a barcode on the image on the left, versus the image of the right, where you see superficially you have an absence of movement, but then at the pleural line, below that line, you see this kind of sandy appearance, and that's because there is lung movement. The lung point is the interface of normal lung sliding and an absence of lung sliding. And this finding when you see the lung point, so both sliding and absence of lung sliding, this is 100% specific for the diagnosis of pneumothorax. When you do have fluid in the lung, what ends up happening is that you can now see anatomy. So in a situation where you have pleural effusion, like the image on the left, you now have fluid within the chest cavity, and now you have a conducting medium for the sound waves. So whenever you see the spine north of the diaphragm, as in the image on the left, there is fluid that's allowing the conduction of these sound waves. And in the image on the left, you can also see a small bit of the lung as well. Versus the image on the right, where you see the spine and diaphragm meet, and then you see nothing north of the diaphragm. So this is an example of spine sign versus the normal appearing chest. Another example over here of spine sign. Now, you will see the spine whenever there's fluid within the chest cavity. This is an example of pleural effusion, but you would also see the spine if you had pneumothorax, pulmonary edema, or pneumonia, because in both of these situations there's an increased fluid content within the lung itself, and now again you can propagate these sound waves to visualize the spine. This example, you can see what looks like a tissue-like structure versus the normal appearing lung on the right, which shows no extension of the spine, and you have a complete absence of any kind of anatomical finding north of the diaphragm. So in this example, what you're seeing is a lung consolidation on the left that's sitting above the liver. B-lines are another lung artifact. These are vertical beam-like structures that start at the pleural line and go the full depth of the lung parenchyma. You can see this in the image on the left versus the image on the right, which just shows a normal lung with no B-lines. Whenever you have a consolidated lung segment, you may appreciate these bright dots that are present within the lung consolidation. These are air bronchograms. They can be dynamic, in which case they move, or they can be static, in which case they're just bright dots that are appearing and don't change with the breathing cycle. Another finding you may encounter are pleural line irregularities. Over here you can see in the image on the left, the pleural line looks lumpy, bumpy, whereas the normal comparison view shows a normal appearing, perfectly linear pleural line. So less than 3 B-lines can be totally physiologic. You may see them in a normal appearing lung. However, if you have more than 3 or more B-lines in any lung segment, this is highly concerning for interstitial fluid. Now, what is the significance of this lumpy, bumpy appearance of the pleural line? Well, you can see this both in cases of subpleural consolidations, as you would see in bronchiolitis, or you can see this when there's an underlying pneumonia.
Stop, look, and listen. Not every tissue-like structure seen in the chest is pneumonia. You can see normal thymus in babies, and a chest wall mass could be confused for consolidation. Clinical correlation is advised.
Now we'll go over a case. This is a 12-year-old male who presents to the emergency department following a high-speed motor vehicle accident. There was significant intrusion on the passenger side of the vehicle. Child presents to the emergency department with absent breath sounds on the left lung field and diminished breath sounds on the right lung field. Child has a respiratory rate of 32 and 91% oxygen saturation on a 100% non-rebreather. His GCS is 13. So here you can see, if you pull out your ultrasound and perform a lung ultrasound on this trauma patient, you can see an absence of lung sliding on this left lung field. On the right lung field, you can clearly see that there is pleural effusion. Case number 2 is a 15-month-old child with 4 days of fever and cough. Child now has labored breathing with subcostal retractions and tachypnea. Her oxygen saturation is 92% on room air. On auscultation, she has diffuse coarse rhonchi with scattered crackles, and there's also diminished breath sounds on the right lung base. What you see on essentially diffusely on her lung exam, in most of the lung zones, you see this lumpy, bumpy appearance of her pleural line that's concerning for subpleural consolidations. You find another finding, which is the presence of a pneumonia on her lung base. Using your lung ultrasound, you have now obviated the need for doing a chest x-ray on this child, as you've diagnosed her bronchiolitis both clinically and sonographically, as well as the appearance of a pneumonia. So in summary, lung ultrasound can help you piece together your patient's clinical lung findings and diagnose their lung condition. So here, when you are looking for sonographic signs of pneumothorax, you're going to be looking for things like A lines with the absence of lung sliding, and you'll likely see a barcode sign on M-mode imaging. In cases of consolidation, you'll see a tissue-like consistency. You may see focal B lines because there's increased fluid with the pneumonia, and you'll likely see ear bronchograms. In cases of pleural effusion or hemothorax, you'll see an extension of the spine or the spinal stripe. In cases of pulmonary edema, you'll see 3 or more B lines in any lung segment. And in cases of bronchiolitis, you'll see things like subpleural consolidations and B lines.